always,
audible.
it's always a pleasure to be with Bangladesh cardiologists, and I'm missing the lovely company of you people. However, I'll speak about the echocardiographic evaluation in congenital heart disease, basics and beyond. The diagnosis of cyanotic congenital heart disease represents the epitome of clinical logic and correct inferences from accurate observations, the diagnosis with gratifying frequency. That's what Joseph Parlap said, and that is his autograph I got 30 years back when I was a student, and now for my book he has written the preface, and he was a great person. Now you know the classification, simple AST, VST period, you all know about it. The rare complex, I remember 5 T's and 3 A's and 2 E's, and miscellaneous are DORV, DOLV, single atrium, single ventricle, those are the things. Now starting with the basics, you all know the basic views, but in congenital heart disease, we give importance to the subcostal view, and then we have to go to the right side for the dextrocardia and also right parasternal, and one space above the short axis, that is the ductal view, and also the suprasternal view. So these are the extra views that we take care in the congenital heart disease. Now when you start the basics, you have to start with the segmental approach. If we don't have the segmental approach, our diagnosis will collapse like this. And hence, remember, sequential echocardiography, the venous segment includes both systemic and the pulmonary veins and the coronary sinus. The great veins are systemic, superior vena cava, LSVC, inferior vena cava, and hepatic vein. Coronary, we have the coronary sinus. Pulmonary veins, we have 5, not 4. And then veno-atrial connections also have to be taken care of, and atrial segment also should be looked for, and the morphological LA-RV should be looked for. If we miss the segmental approach, we will miss the diagnosis. As you see here, this is the dilated LA and the LV, and what do you see here? The superior vena cava is draining into LA. So this patient will not have anything otherwise, but the child will have cyanosis and will miss the diagnosis if we do not see where the superior vena cava is draining. When we come to the inferior vena cava, it is visualized very well, and especially when it is dilated and the spontaneous echo contrast is seen, we have to be very careful. And the bicaval view is the best in the transesophageal echocardiography, where you see both the SVC and the IVC in a one plane. So in subcostal view, you have to look for the aorta and the IVC. And normally, in the situs solitus, aorta is to the left and IVC is on the right. But in the situs inversus, it is reverse. Whereas in situs ambiguous, we are not able to make out which side it is. So in such cases, you have to go beyond, and computed tomography can tell you that this is the CT angio in the situs ambiguous, mesocardia, interruption of the intrahepatic IVC with hemiazygous system, and the RSVC and the LSVC both draining into LA, and these are the things, and also with the polysplenia, and all these things can be made out in the CT. So we have to go beyond the echocardiography. Whenever the IVC is dilated, the SEC is there, and we have to look what is the cause for it. And the usual causes are pericardial effusion with tamponade, constrictive pericarditis, restrictive cardiomyopathy, and the right ventricular dysfunction, and RA thrombus, and also the aortoventricular AV fistulas. Whenever the SEC is there, you must think of the impaired flow into the stasis or the membrane obstruction. And you can see here that this patient was cyanotic and had a DORV. In a case of DORV, on top of that, there is a massive pericardial effusion with the mesothelioma attached. So in congenital heart disease, never be happy to make one diagnosis and you have to look for the other abnormalities. When we come to the basic subcostal view, you can see that this is how you see the structures, and this is the best view for looking at the atrioventricular septums. Now, when you look at here, you can see that if the apex is to the left, it is livocardia. It is to the right, it is the dextrocardia. And if it is in the middle, mesocardia. If it is a mirror imaged dextrocardia, the LV will form the apex. If it is isolated dextrocardia, the RV will be forming the apex. So this is how we identify the site. And then when the parasternal long axis, this is how you can see all the structures. And here the mitral to aortic continuity has to be looked carefully, and the interventricular septum has to be looked very carefully here. So here you can see that when you see the segmental approach, the LV is draining into the pulmonary artery, that is which is a branching vessel, and the RV is going into the aorta, which is the arching vessel. So this is the TGA. So this is how when you go to the segmental approach, this is how you can make out. And here you can see that mitral to aortic continuity is not there. There is the thick ridge indicating that this is the pulmonary artery, and you can see that pulmonary stenosis is there, turbulence is there. So this is the DORV. So in the parasternal itself, you can make out the difference. So clinically, we make the aortic regurgitation, but then echo can tell you what is the cause for the aortic regurgitation. You can see that here, aneurysmally dilated cusp is prolapsing, causing the aortic regurgitation. So the MOD can make out that. Apart from that, in the parasternal long axis view, you can see if there is an annular dilatation, ascending aorta dilatation, or the ascending aorta is narrow. All these things can be made out. Then in the hypertrophic obstructive cardiomyopathy, speckled appearance of the spectrum as well as the SAM can be made out. And here, especially when you take the MOD, the SAM is very nicely seen, and premature closure of the aortic valve. You can see that how it is fluttering and closing. Normally we have the box, and here it is the premature contraction. This is the typical hypertrophic obstructive cardiomyopathy. In the same parasternal long axis view, you can also see the supramitral ring as well as the divided left atrium, that is the port triatrium sinister. And whether it is fenestrated or not can be seen. But now we have not only the 2D, 3D, in the 4D echo here you can see that on the RA side you have the coronary sinus, on the LA side you have the membrane, and this is how the 4D echo looks exactly like that. And in the 4D echo itself, we can see that this divided right atrium or port triatrium dexter is not fenestrated and it is intact. So in this patient, I have done the balloon rupture of this membrane to relieve the congestive cardiac failure in that patient. So we have to go beyond to make the diagnosis and give the best treatment to the patient. So this is the subaortic membrane. And many times subaortic membrane is missed if it is very close to the aortic valve. You can see that the cusp is away from the membrane, and now it is known that this membrane can grow over the period and it can become like a tunnel, and this patient had a tunnel like subaortic membrane, the gradient of 170, so this had to go for the surgical resection. Nowadays we don't do the balloon dilatation for the membrane, they all go for the surgical resection. This is the apical four-chamber view. In the apical four-chamber view, we see all the four chambers very well, and interventricular septum becomes the part of the LV. And here you can see that when there is a RV dysfunction, it becomes part of the RV. So this is the large AST that you see. This is usually the pediatrician, they invert the image, and this is how you see. In the transesophageal, you can also see whether the rims are adequate or not, and this is how in the adult we do that. And now beyond, if you go intracardiac echo, that is ICE, is an invasive one, and this is the probe in the right atrium, and while doing the large AST closure, the intracardiac ICE is done. Where I was trained in Chicago, Hijaji was using this, but this is expensive and it is not possible in our country. Gone are the days when we used to see this device in the autopsy, whether the endothelium has gone. But today we have the 4D echo. You can see that instead of giving 3 months, 6 months aspirin after the device closure, we can do the 4D echo, and how beautifully the whole device has become endothelialized, and that's how we can decide whether aspirin to be stopped or not. So AST, we were wondering how to measure the rims, but now we have to see whether the size is all right or not. In the 4D echo, we can see from the RA side as well as from the LA side, and not only that, we can also make out the shape of it, the size of it, and whether it is a small, large, because many a times after putting even the large device, there may be a portion of it where there is a residual shunt because of the shape of it. So this is a 10 months old baby and a very rare condition. And I was wondering what it is. I thought it is a non-compaction at the apex and the Swiss cheese VST, and then I was not able to make out the 4D. So with the 2D, I sent for the CT, and in the CT we could see that there was a double-chambered RV and highly trabeculated, and then they gave a doubt whether there is a VST or not. Now, since the child had pulmonary stenosis, and I wanted to make sure, because if I open the pulmonary stenosis with the balloon, the VST might become worse and then the pH may occur. But look here, the non-compaction Samir was describing, and the non-compaction is so beautifully seen in the 4D. You don't require any criteria, and the double chambered, and you can see that interventricular septum is intact. So I went ahead and did the balloon dilatation of the pulmonary stenosis, and now the child is 2 years old, and this is the mitral valve, tricuspid valve, and that is the interventricular septum, which is split, but there is no flow across it. And this is how you can see that interventricular septum is intact, and this was not a Swiss cheese, it is a double chambered right ventricle with the pulmonary stenosis. That's how when we go beyond, we can make the decision with more precisely. So this is the triology of fallow, a tight pulmonary stenosis with the PFO and right to left shunt. With the severe TR, with the balloon dilatation, the child improved. So this is the apical 4-chamber view, and I showed you in the apical 4-chamber view. In classically, the tricuspid valve is more apical, and here you can see that the more apical tricuspid valve is on the right side. So this is the morphological RV. And as a result, this is the corrected transposition of the thing with the VST. So in the apical 4-chamber view, you can also see the whip-like movement of the anterior tricuspid leaflet, and the subtle leaflet is adherent to the interventricular septum, and this is the Epstein's anomaly. And in this Epstein's anomaly, you can clearly make out the RV, atrialized RV, as well as the RV itself. And here you can see that the overriding of the aorta is there. Overriding of the aorta is there, and the large subaortic VST is there. And you can see that the annulus is very narrow, and the bud-like valve is there. So this is the absent pulmonary valve with the free pulmonary stenosis and the pulmonary regurgitation. And this is a special subset of tetralogy of fallow where it is absent. We must also look for the absent right pulmonary artery. You can see that the right pulmonary artery is absent, and here you can see that the left pulmonary artery is absent, and that is called as the Dubuque syndrome. And this is a different cup of tea for the surgeon for the correction. This is not like a regular intracardiac repair. In such cases where the pulmonary atresia is there and the multiple aortopulmonary collaterals are there, the best thing is we have to go beyond and get the 3D reconstructed image of the CT angio to make the unifocalization. So here you can see that there is what appears like the ostium primum AST, and in fact it is the dilated coronary sinus, that is the intracardiac TAPVC. So you have to look where the pulmonary veins are draining, and that is the inverted image along with the confluent chamber in the behind the LA. So this is the supracardiac TAPVC. You can see that in fact the figure of 8 is explained in a case of X-ray, but in an echo itself you can see the 8 figure. So beautifully you can see the vertical vein, horizontal vein and the superior vena cava, and this how the figure of 8 can be made out even on the echo. So whenever there is a ground glass appearance in the X-ray and the child is very sick in the neonatal period, you must look for the infradiaphragmatic TAPVC, and here you can see that there is a turbulence and the continuous flow in the hepatic portion of the IVC, indicating that there is a infradiaphragmatic TAPVC which is obstructed. And the complete AV canal defect itself is a chapter, and last month I had spoken to the Bangladesh cardiologist, and this is a very important thing that echo can make out. And post-operative evaluation also is better than with the echo. So this is a patient where the patch is given, and you see the background patch is adynamic, whereas the interventricular septum is dynamic. So this is moving very well, but the patch is not moving, and the patient has got the aortic regurgitation in the DASLA and the residual VST during the systole into the RV. So the two jets indicate that one is the residual VST and other one is the AR, indicating that the patient requires redo surgery. In the short axis, we have to look at the two papillary muscles, and this has to be done very carefully in the pediatrics. If there is only one papillary muscle, that indicates that there is a parachute mitral, and this is attached to the apex. So whenever there is a parachute mitral, you must look for the supramitral ring and also look for the subaortic or the supraaortic obstruction, and apart from that, coarctation of aorta, and this is called as the Schoen's complex, though rare. And one thing that you must remember, that in congenital you have to look for all the abnormalities. So this is a single ventricle, and you can have the single ventricle with the double inlet single ventricle, that is the LV type, and that can be seen in the short axis. In the tricuspid atresia, you can see the inverted image also, the LV function and the AST and the VST and the gradient all can be made out with in the tricuspid atresia. In the apical four-chamber view, you can see the overriding in tetralogy with the pulmonary stenosis. You can see the supraaortic stenosis with the gradient that is in the Williams syndrome. So apart from five-chamber view, then you have to go to the short axis. In the short axis, this is how you look at the RVOT and the pulmonary artery and the branches and the aortic valve. And the bicuspid aortic valve is the commonest congenital heart disease. The slit can be horizontal or vertical. You can have quadricuspid valve also. In the short axis, normally it is a cup and saucer-like thing. The cup is the aorta and the saucer is the pulmonary artery. But whenever there is a DTGA, you have the side-by-side aorta and pulmonary artery at the same level, called as the owl's eye, and you get like two rings like this. And if there is a malposition, there can be anteroposterior position. So the pulmonary artery and the aorta, there may be malposition may be there. And in a single coronary ostia like that you see here, in an infant and the newborn babies, the coronaries are very nicely seen, but when you go to the bigger children, it becomes difficult, and the coronary anomaly constitute 10 to 12% of the pathologies, and if this anomaly is not told, the surgeon can cut while doing the infundibulectomy and get into trouble, and hence we go for the CT picture, the reconstructed image, and you get beautifully all the varieties of the anomalies that you see. In the same short axis, you can see that the AP window can be diagnosed very well, and after the device closure, the echo also helps in making out whether your device is in position or not. So in the suprasternal view, many times the picture is not very clear, and here again we have to go beyond to see the reconstructed image, and here you can see that from the pulmonary artery, the duct is continuing as the descending aorta in the interruption of aorta. So we have to go for the ductal view one space above to make out the ampulla, the length, and before deciding for the device closure, the proper assessment is very important. associated TGA with pulmonary stenosis, and here you can see that the bidirectional glen that is done also can be made out in the echo. So this is the inverted image, and this is the patient with the TGA with the PAPVC. So this is how even the complex congenitals can be made out. Here you can see that it appears as if it is a double aortic arch, but it is not a double aortic arch. It is the tunnel is there. This is the right coronary artery, and just by the side is the tunnel. So this is the aorto-right ventricular tunnel, and with the single coronary ostia, and as a result, it was easy for me to do the device closure, and at the end of the tunnel, you can see the device beautifully sitting without any residual shunt. And this is the aortic atresia, extremely rare, 0.03% of the time, but gone are the days when we would make the diagnosis after the birth and struggle, and this now we can do it in the fetal echo itself. Even ectopia cordis can be made out very beautifully, and all the conditions where the medical termination of pregnancy has to be done can be done with the fetal echocardiography. Now I'm able to diagnose the fetal echocardiography, the most of the things very well. And the most recent one is the blood speckle imaging.
Madam,
And here, this is one where we can make out where the, yeah, I'm finishing, sir. So here the RV function is very important in children, but this was not possible. Now with the Podi echo, RV ejection fraction can be made up. To conclude, in the last 5 decades, echocardiography has evolved into most useful and non-invasive, cost-effective diagnostic technology in the management of congenital heart disease. From M-mode to 2D, 3D, 4D, Doppler, color Doppler, transesophageal, intracardiac, fetal echocardiography, the journey has been fascinating and rewarding, which has made us look beyond the basics. And this is how it looks, the 2D, 3D, and the 4D. Now with the CT, it is like the guided missiles, very accurate and very precise, and the errors are much less. So here are the two fathers, that is the Naveen C. Nanda and Pigan Bam. And here I would like to say that the pathologists make the perfect diagnosis, alas, and late. They too late. Echocardiographer makes not so perfect diagnosis, but in time to save the precious life. And thank you very much for the kind and the patient hearing. I wish everyone a very, very bright and happy Deepavali. Thank you very much.